Very good evening to all of you. And this times it is only Vanakkam, so be safe, all of you. Main thing is none of the photographs about a person or any other example shown in this presentation doesn't mean any harm to anybody. So NABH, as you all know, we have been talking about NABH for over a decade. Now it has become very important. Somehow, all these things are practically very useful for the safety of the patient, the attenders, and the employee. So we need to know NABH. I think I've given a 15 question answer a questionnaire in the group. You can all just go through it. National Accreditation Board for Hospitals and Healthcare Providers. It is very important now because insurances they will depend on this particular NABH. You will be surprised to know it is a lot safer to get travel in an aircraft rather than get treated in a hospital. That is how much of errors and uneventful things that are happening, eventful things that cause unnecessary problems to the patient in the hospital. Not only here, we are talking about developed countries also. So the safety is the most important. Here in US, you can see it is a third important killer, the medication errors after heart disease and cancer. These are two couple of instances that have occurred. One North India, one in the Eastern India. Both the instances on top, there were incidences where there were loss of life. But the one below was a big hospital in Bangalore. They had a fire, major fire. Within 13 to 14 minutes, they evacuated everybody and nobody had any problem or no death occurred. So that is because of the certification they had. And one of the hospitals on top had actually lost NABH about a couple of months before the accident. So this is a race which you're going to see now. At this point, what do you understand? There is one, big wild cat chasing another deer. So whatever happens, whether it is going to be the lion or the tiger or the deer, each one has to run faster than the other to survive. So in today's world, we were number 3 in the country as far as number of surgical procedures are concerned. And to remain in the third spot, it is not the number, it is the quality, safety that counts. And we should keep running to be there. Otherwise, we'll get lost in no time. And that gives you more credential with good, beautiful results like very minimal infections and better than the best in the world. So that is how it is. So going on, now, Insurance Regulatory Board and the NABH got together in 2016 to bring in the entry level standards because many of the older hospitals cannot get the accreditation because of statutory compliances. That is why we have 9 hospitals in the Arvind Eye Care system which have entry level, and 2 are yet to get it immediately, and another 2 hospitals in Chennai and Tirupati, maybe Kovilpatti, will go for accreditation. Okay. So these are the standards. So basically entry level is not an accreditation. We divide the hospitals into 2 groups: entry level small healthcare organizations or healthcare organizations. Below 50 beds, we call them small healthcare. Above 50 beds, we call them healthcare organization. So here, our hospital is a healthcare organization. According to the Clinical Establishment Act, we have 169 beds in the hospital. Whereas Tirupur, Udumalpet City Center are all small healthcare organization. Either we can go for entry level in a small healthcare or healthcare, or we must go for accreditation, for which we have the eye care standards. This is the regular hospital standards, which was released about 6 months back, 5th edition. It gives a lot of inputs for all the elements that are applicable to us. For example, when I say element, for an entry level hospital like ours, we have 167 elements to comply. And for a small healthcare like city center, we have 149. Out of this, 10 or 12 or maybe 13 will not be acceptable because we won't have gynec, we don't have radiotherapy in some of the hospitals, and so on and so on. So this is world over. If you have a patient who is satisfied, they come to you and go back happily, they are likely to bring in other 6 patients. But on the other hand, if a patient becomes unhappy due to various factors, they will prevent 26 others from coming for our hospital. The initial perception when we start getting into NABH, it's a difficult process. We say it's difficult and to do and comply, adds very little value. We do it for the sake of getting NABH, costly and difficult. But the reality is it gives a brand name, it gives confidence, it effectiveness, risk levels are reduced, and safety is good. It gives an enhanced quality. So it is a standard practice, recognized brand name. All this is okay. Most importantly, it comes under the Quality Council of India, which also comes under the University of the Ministry of Commerce under the Government of India. So it has got a lot of value, and it is very good for the third party to assess a hospital. So this is the quality pyramid where we start off from safety. It is all patient centered. At Arvind, across the Arvind ICA system, we have all these 10 safety goals, whether it's a patient and the correct procedure, IOL power, managing systemic emergencies, infections, including spectacles, physical safety, and high risk ophthalmic patients. So National Accreditation Board for Hospitals and Healthcare Providers, it belongs to the Government of India under Quality Council of India. So it gives accreditation. Like in US, you get it from JCI. Okay, it benefits the patient. They are the most important beneficiaries. Second will be all the staff, and of course, definitely the management also benefits from this whole process. So this I said 149, 167 for entry level. For a eye care organization, it will be almost double, 302 elements. Basically, we have 10 chapters we talk about. The first 10 chapters are patient-centered chapters. The first 5 chapters are patient-centered chapters, and the next 5 are managerial standards. So these will be giving inputs as to how we must take care of all the. Though we have 14 hospitals in Arvind Eye Care system, each hospital will be a standalone hospital. If I want to say element, this is one example. One standard says services are being clearly defined. So what are the services? Where it will be defined? For any hospital, the Apex manual is the main manual which will talk about the hospital. So it should be there in the Apex manual. Defined services are prominently displayed. Where do we have it? In the front, when you enter, or on the side 30 counter. So patients and everybody should be able to see what are the scope of services we have. Lastly, all people who are related to patient care should be aware of all the services. For example, in Tirupur, we may not have oculoplasty. We may not have surgical retina. So that people should be, they should know what we give. We are giving glaucoma. We are giving IOL cataract surgery. So that should be aware. So this is how we have clinical services, like all the clinical aspects, and the supportive services in the form of prosthesis, eye bank services, micro lab, Vicam lab, and so on. So this is the basic model. The structure is all the staff, department, equipment. That is the basis on which the hospital functions. The pathways, protocols, everything are the processes. Finally, what is the outcome of the disease or whatever you're planning to do? As a doctor, you should be aware of all the case record related details. Case record means every documentation, whether it is electronic or hard copy. Everything to do with OPD investigation, everything to do go with operation theatre. Then you have the infection control practices, lab, then you have the safety and antibiotic policy to be followed. This is there everywhere. Our vision is the elimination of needless blindness. This you should be aware of what is happening. The statutory documentations are whatever the government requires regulations. We need to have a pollution control board. If you don't have a certificate from them, it is going to be a crime. For fire license, biomedical waste, and so on. Okay. And these are the ways you have to collect it and make sure they are not off after the expiry. It should be renewed properly. You need to have MOUs wherever you don't have CT scan, MRI, some pathological lab services, medical gas, canteen. Even if you have outsourced services like canteen, coffee shop, everything security, you should have a MOU. Better to have a license tracker so that nothing goes off without a validity as a expired document. These are some of the things which you already discussed. Apart from that, the lift, the boiler, the generator, the canteen, everything should have a absolute license or MOU. Now you have many patients coming into our system, but what happens? We have to identify some people which are these orange colored people. Who are they? They are the people who are, mother having a nursing child, a pediatric patient, maybe an old patient, patient on a wheelchair or a stretcher. They are called vulnerable patients. and those people who require treatment immediately. So they have to be identified and seen on priority. Emergency has to be seen immediately. So we have this color coding tags which will be tied to the patient's wrist. So then the flow of patients should be as per protocol. I'm not going into it. If you follow the correct protocol, there will never be a mistake. Vision, then you have your duct and IOP done, BP done, and then you see the doctor. Unless it's an emergency or a chemical injury, you don't break the protocol. The entries in the case sheet should be absolutely fantastic and good. Most important part, whatever we have for a patient is a medical legal document. You believe it or not, whether it's a hard copy or electronic copy, it is a medical legal. And what a patient carries with them, either in the form of discharge summary or the drug prescription or a case summary, everything is a legal document. They can stand very high in the court of law. So, for example, discharge summary, we have a very good process. We have the complaints, we have the investigations, and everything. All should be signed by the doctor with the registration number. We don't give discharge summary only for the surgical patients. We give discharge summary for patients leaving against medical advice, patients discharge against medical advice, and of course the medical legal cases. It is their right for them to take. So we have a form for everything. We have a form. It should be properly filled and given. Any record, there should be high level of confidentiality. Now that all of you are using your EMR, you must be very careful with your login password. If somebody can misuse the login password, you will end up giving the details to a patient, attender, or somebody where it can be misused in the court of law. You don't disclose anything about the patient to anybody unless it's a disease like COVID-19. It is a notifiable disease. Then you can give the details to the proper authority. According to the Medical Council of India, you need to keep the inpatient records for 3 years, but ideally we should keep it for a longer time. The OPD records separately, IPD records. If they want a copy within 72 hours, it should be given to the patient or the attender who is authorized by the patient, or if it is a young patient who cannot collect it themselves. Copy of the certificate, whatever certificate you give, you must have a copy. Ideally, in the duplicate copy, they must sign and say, I have received the original on this particular date, so that you are also sure, they are also sure. Tomorrow they can't say you're not given. And ideally to computerize everything. Retention period, I said 3 months, 3 years. Even if you want to destroy them, there should be a policy. It should be notified internally and externally, and then only you can destroy them, shred them, and throw it without keeping any evidence of those case records. Any procedure, whether it is diagnostic, laser, or surgery, you have to do a proper pre-op assessment and diagnosis. Informed consent, we have more than 100 informed consents at Arvind. Policy to prevent any sentinel event like a wrong guy, wrong procedure. It should be done by qualified person. What do we mean by qualified person? That means you must be credentialed. Your qualification is number one. You have MS, DO, DNB. Then you must be privileged. So your HOD will say you can observe these cases only. You can do these cases with assisted. And third group would be you can do it independently. This privileging can be done by the HOD, and for the HODs it is done by the head of the institution. The notes and post-op plan should be clearly written. Everything should be documented. The flow in the theater should be HIC, unidirectional flow. No crossing over of infective and sterile items, or used and sterile items. Either it is equipment, instruments, and all those things. Whenever we share a consumable between patients, we must have a policy to make sure there is no cross infection. Now, this is something which is important. When you see a suspected case of injury or probable case of MLC, you tell them immediately to put the sticker. Otherwise, they will be lost within 2 to 3 years. After 3 years, if they come from court of law, you will not have any of these details. So once they say MLC, it will be kept under lock and key, minimum of 10 years. If it goes to the court of law, till it is disposed by the highest court of law called the Supreme Court. So it is essential to have it documented and kept ready, updated. These procedures are their standard operating protocols, or how you do BP, how you check duct, how you, everything has got a protocol, and how you manage diabetic retinopathy, how you manage cat. Basic algorithm should be followed, but there will be deviations as per the need. So it is should be documented so that it is done universally across the system. Another documentation would be antibiotic policy. What should be given for ACCO? Not 10 types of infection antibiotics, not 10 types of steroids, and so on and so on. Every imaging equipment, topography or FFA or OCT should be calibrated so that you get good results, good quality, specificity and sensitivity. Okay. The scope of services of lab, whether it is biochem or micro, they should write it outside, number one. Number two, they must say the turnaround time. That is, if I give my blood at 5 p.m., I will get the results of blood sugar with 6 p.m. If I give a culture today, it will get come after 48 hours or 1 week or something. So first will be the scope of service. Second will be the turnaround time. And third would be the most important critical events you must know, and then the cost. What will be displayed there would be the scope of service, second turnaround time, and the cost. Another thing you must know is this critical values. This is to be for you all to know if it is a non-diabetic, what is the critical value. If it is a diabetic patient, what is the critical value. So you say 140 normal. What is critical value is above 300, above 500, whatever it should be written. Say for non-diabetic, 450 milligram is the norm here. So these critical values are seen. The lab person should inform the doctor who has given this order. You must sign so that you do not miss on a critical value which could be critical for the patient. That is one thing everybody should be aware of. So here if you see, what are all these things you are going to see? They are all not only tablets, drugs, medication, oxygen, blood and implant. So according to NABH, anything that goes into the patient's body is called the medication. So they all come under the chapter management of medication. So here many of the errors occur when you used to write the prescription or in the drug chart, too busy or being illegible, mistaken drugs, many drugs, similar drugs and so on. So this is very should be much avoided. You should never have any kind of mistake due to all this. This Medical Council of India has said you must write legibly and generic name. Generic name is not possible because at this point similar drugs do not have the same potency, so that is okay. Ideally capital letter, but for NABH it should be only capital letter. Even it is in EMR, you make sure it is only in capital letters. So here you can see an example. There is a drug given for 2 times. There are some abnormalities here. What are the abnormalities? It says BID. In the case sheet, it is right. It is okay to write BID. But in the prescription, you have to write as per what the patient will understand. 101, 111, and how many days, what is the duration. So this is something which was given. In the pharmacy, they gave a Combigan drops because they thought it is Combigan and they gave an anti-glaucoma medication instead of a anti-allergic medication. So one bottle review. So all those things should be very specific as per the drug prescription. Otherwise, it will land up in a wrong drug being given to the wrong patient. So if you see all the patient details, MRD and all those things, then next would be the clearly legibly written capital letters. What is the strength? Then what is the dosage and what is the duration? Of course, your signature, your name, your registration number is essential. If it is a pediatric patient, ideally we should also write the weight of the patient. We have medications arranged across the hospital, not only pharmacy or OPD, including a sample medicine, OT, crash cart, and so on. Everything should be arranged as per the alphabetical order only. It is very important that you, because it is easier to trace them. Number two, whatever drugs come in first should be used first. First in, first out, so that you don't end up with a newer drug being used later after it gets expired. So here you can see one first example, Zoxan and Zocon. They sound similar, but one is an antibiotic, the other one is an antifungal. So this is something which is called as look-alike and sound-alike drugs. We have some modes of seeing that you give the correct drug. We have blue color coding, that means they are sound-alike drugs. Green color coding, that means they are look-alike. So both ends it will be kept. Zocon will be in one end, Zoxan will be in. So you compare and then give. This is to avoid any major mistakes when LASA they are called look-alike. What are these high-risk medications? Any medicine that has a very low therapeutic index, even a small dose can cause, increased dose can cause abnormality to the patient, like adrenaline, atropine, methylprednisolone. So here we have a color coding for high-risk medication as red color. You must also have a list of all the high-risk medications being used wherever these medicines are used. Number one. Number two, it should be kept under lock and key. Number three, expiry should be checked every day for this high risk and emergency medicine so that you never have a zero balance. And number four, when they're going to give it in the pharmacy or whether they're going to administer in the ward or OT, it should be doubly checked so that you don't give the wrong medication. If it is in the prescription, it should be checked with the doctor who is giving the prescription to make sure you give the right kind of drug to the right patient. So these are some important rules to prevent abnormal. Here you can see in the crash card, you have a combination. You have look-alike medication, you have sound-alike medication, and iris med. All this will give you a clue so that you are very careful. You don't mix up with two kind of different drugs. Here you can see there is one thing in the fourth column, HKR50, that says upon the batch number. According to the batch number, the fifth column will say expiry. Supposing we have 3 batches of paracetamol, one is A, B, C, each one will have a wrong expiry. If you put the wrong batch number, the wrong expiry will come and the balance will not be tallying when we count. So remember, the expiry should come. For example, if somebody is giving 3 tablets to you, make sure they put it in a cover, they write the name of the drug, batch of the drug, and expiry date and dosage. The remaining medicine also in the pharmacy should be kept so that you are also aware when the expiry is there. So that is important. So expiry checking is usually done once a month so that before 3 months we remove the drug and give it back to the company to replace it so that we don't lose. Daily checking for emergency medication and high risk medication, random to make sure that everything is being followed. Whenever a medicine is given which is expired or contaminated, then you have to recall. That means we issue a drops today, patient goes and finds out it is frothy or expired. They will bring it back. So whenever you find this is wrong, you find out the batch number and see to whom all it has been given so that they are all recalled. So this is called recall. Another important recall is you will open your bin in the morning to take a forceps. Then you can see the sticker color has not changed. That means that whole batch has not been autoclaved properly. Tell the OT and tell them to recall all the instruments and bins that have been autoclaved in that particular batch. So these are called recall policy. Verbal orders occur very much when you operate on a case. You have a vitreous prolapse or vitreous bulge. You want to give Diamox or mannitol. So from the theater, you call the sister and say for patient ABC, you give DEF injection. Okay. So after you tell that, the staff should say, sir, for patient ABC, DEF has to be given immediately. It is called repeated. Once you order, they must repeat so that you confirm there is no problem. After you confirm, they will write in the case sheet advised by Dr. DC this at 11:50 a.m. and medicine administered. Within 24 hours, if you have ordered this verbally, you have to go and sign in the case sheet. Then only that will be legally correct because nobody other than the doctor can prescribe a medication. If a doctor is taking the order, that is different. But if a paramedic is taken, no way they can use it. Okay. So that is about the verb. So when the patient comes, we have many people with diabetes, hypertension, cardiac, asthma. So they can use their own tablets. Only thing, they must be written clearly in the case sheet so that if there is a problem, acute problem, the doctor who's treating should know what drugs he is on, what is the problem. Parenteral drugs are usually given only by the staff in the hospital as an inpatient. You may have expired medication or wasted medication or remnant medication. They all go into this yellow color bin in biomedical waste management. When you're loading drugs, say Avil whenever you load one, you have to label the patient's name, the MRD, the date. Then you have to write the name of the drug. The strength is there. If it is there, you write the strength, the route, and what time it has to be administered time. So this labeling is not done. You'll end up in a mixture of giving different drugs. So when you have medication like this in the theater, you should have the batch number expiry. You must remember at Arvind, for every new batch of medicine being used in the theater, one sample testing is done to make sure they do not have any kind of contamination. So you must be able to recall them if there is any abnormality. So when abnormalities are there, medication errors are there, you must report and find out what is the abnormality. There could be adverse event. So adverse event could be because the allergy to the patient has for the medication, or 3-4 patients may have allergy. That means the drug is a problem. For example, Avastin was a problem across the country. So that whole batch was recalled. So that is very important. So adverse events are also noted. Adverse drug events are also noted. Ultimately, this is the formula: right patient, right medication, right instruction to be given. So patients have all got rights and responsibilities. So they have the right to get respect, confidentiality, disease. They should know about the disease. They have choice of treatment. Medicine could be done, laser can be done, surgical can be done. But what is the advantage, disadvantage? Whether complications will be there, or they even have the right to refuse. Similarly, the responsibility is to give complete history of the case pertaining to them, give a consent for treatment, respect hospital, come whenever advised to come for a review and follow up. So this is, we are transparent as far as the procedure is there. Every tariff should be transparent. You must also tell them, there could be a group 3, you're doing cataract, you can get a zonal dialysis. You may put an alternative lens. You may not be able to put a lens. Another surgery. All that should be clearly told. That is the idea of G, not only for the seniority of the surgeon, also this also. So we have many methods. We can mark the eye. We have the band in the same kind of wrist. So, but in spite of all that, you have to recheck before you do your surgery. But at the end of the day, it is the person who's operating who's solely responsible for the patient. We take a consent form on the first visit, which is valid till they come to the hospital, any number of years. But that will also say you can take photograph, video for scientific purpose. But for all other procedures, you must take a consent form. You must have at least one witness. Most important, patient details, diagnosis and procedure. Then the signature should be patient, unless it's a pediatric patient or a patient who's unconscious, who's mentally retarded. The legal representative can sign. Make sure you get at least one witness signature. Along with your signature, the registration number, date and time should be there. Every detail should be filled properly. Anesthesia also, we have the same kind of consent. They have to fill in all the things. So depends on the mental capacity and complete information, everything to be conveyed. In your, for example, if you take our local anesthesia form, it will say what are the advantages, what is the alternative, what are the disadvantages. So that's how you should be giving your consent form for any procedure. Okay. So this is complete form for any consent form. This is another thing. Any patient feedback should be taken seriously. Find out what it is. If anything has to be done, take proper action. Infection control is the most important thing. We were talking, and we are even better than the best organizations in the world as far as endophthalmitis. Arvind, across the system is doing, we have got a very low endophthalmitis. We have succeeded in preventing an endophthalmitis in a surgical patient. But with COVID-19, we don't stop that. We continue to be very vigilant against the endophthalmitis. But with COVID-19, it is surgical patient, plus all the staff, all the patients, and all the attendants you want to protect. That is infection control. Across the world, there are many causes for hospital acquired. In a eye hospital, it could be conjunctivitis or the surgical site infection. So 1 in 31 hospitals have at least one healthcare associated infection at any point of time. The incidence could be as high as 13% or as low as 1%. So what do you mean by infection control? You don't want infection to spread from one person to another in the hospital. Standard precaution when HIV and all those things came, all patients are supposed to be considered as infectious. All blood and body fluids infectious. All unsterile needles and other sharps to be infectious. Now this has got modified in COVID times as all people are potentially infectious. Persons and air around are infectious. All use surfaces to be considered as infectious. Okay, so these are all the procedures: hand washing, your preparation, antibiotic, needle stick, spill management. Everything is part of infection control practices. And here you can see in COVID-19 times, most of these things have got enhanced. So that is important. In a theater, if somebody has to get an infection, it can be starting from the team person to the povidone iodine. Anything can be a source of infection. So that is very important to be vigilant to prevent an infection rather than treat an infection. We have the infection control committee where our senior medical officer is the chairperson, and it meets once in 3 months and whenever necessary. Hand washing is the foundation of infection control practices. If you do these 8 steps, none of the hand would be exposed to an infection. It will be clear. If you don't do it properly, a 10% infected area will make the rest of the hand infected. That is what you must understand. The surveillance in the theater, the ones on the top left is the class 5 indicator to make sure you have autoclave 3 parameters. You have the temperature, pressure, and the time. All the 3 are good only, it will change. The black rings are the Bovidix test to make sure that the autoclave becomes total vacuum. It assesses whether the vacuum is good or not. And finally, we have the biological indicators. The biological indicator, they have Geobacillus stereothermophilus. These spores are destroyed under normal conditions. If they don't get destroyed in their culture, that means your autoclaving, your process is not very good. I'm sure all of you are aware of this new form. It's called the WHO surgical. Sign in is before your topical or a local or a general anesthesia. Time out is before you start operating. Sign out is before the patient leaves the theater inside the. Why do we do all this? Even if there is a error at the end, there is going to be a wrong surgery, wrong eye, it can be found out. And even before leaving, if you find out there is something wrong lens, you can still make some corrections. So this is an absolute essential thing to make sure you don't get any sentinel event. PPE, I'm sure all of you are thorough and using it more than that is needed right now. When a needle stick injury occurs, 300 out of 1,000 patients will develop, persons or get a needle stick will get hepatitis B. Out of 1,018 can get hepatitis C, and HIV 3 can get. So it is important to manage every needle stick injury, whether you are immunized or not. Now, the chances of blood being positive for COVID-19 is very, very low. There's only one study which says 1% of the blood only have been found to be positive. But BMW, biomedical waste improper handling, at the hospital, only 15% of the waste is infectious. But improper handling can make that 100% infectious. And you can have all the people, not only in the hospital, outside the hospital, animals and the environment can be affected. So this is all I think I'm sure you can. This is what we are following at Arvind, the 2018 amendment and of 2016. In COVID-19 hospitals, they must put a double cover, decontaminated sodium hypochlorite, and have a separate register. But unfortunately, we are not a COVID-19. Most important, wherever you are using this biomedical waste, it should be segregated by the person who is using it. Not put it in a tray, put it together, then take it and put it separately. That is the most important thing. Wherever it is stored, usually it has to be taken within 48 hours by the agency. For COVID-19, it should be taken within 24 hours. It should be lock and key, properly color coded and kept along with that. This is the area where all this are being disposed in Coimbatore near Vellaloor. It is a really sickly place with everything being strewn across. So this we have to visit every year to make sure that they do it. So here you can see what are the things which should never be done. How you maintain your slippers, your grouting, everything. All these are root causes for infection to occur, and so many indisciplinary things that will cause abnormal infection to the not only the staff, to the patients also. You have to follow the theatre discipline correctly. Here you can see the person who is unsterile is crossing over the operating area to pour the saline. So absolutely not wrong. You have a total sterile area. You should not. Here you can see how the person is cleaning is totally not acceptable. You have to either follow one direction or figure of eight pattern, so that once cleaned area should never be cleaned again. That is the rule of cleaning in the operation theatre or anything. So this is something
Protocols for
you
effective
must know.
hospital
Most of
infection
you will
control.
know. Can you hear the
Biomedical Waste
voice?
2016 rules color
Just raise your
coding.
hand.
In the yellow color
Can you
bin,
hear the
soaked waste with blood or body fluid, lab waste, linen, expired and discarded medicines, and anatomical waste are disposed. In the red color bin, plastic bottles, plastic syringes, strips, gloves, and intravenous tubes are disposed. Blue color is predominantly for glass.
Now we use
IV
cardboard
bottles,
boxes for
ampules, vials, and glass slides. Metallic implants are also disposed in blue color.
ideal to
Needles
cut
are
the
first
needle.
cut, syringe goes into the red color bin, and the remnant needle goes into the puncture-proof container.
This should be a translucent white container now.
General waste such as stationery, plastics, and food items go into the black or the green color bin. Let the waste of the sick not contaminate the lives of the healthy. Follow BMW rules. Spill management is another important aspect of infection control. Spill could be blood or any body fluid. As soon as there is a spill, people nearby are evacuated. Take the spill management kit and wear personal protective equipment like gloves, mask, and cap.
Even the footwear should
Mark the area with a chalk. Take freshly prepared 1% sodium hypochlorite solution
chloride
and pour it on the spill within the marked area. Leave it like that for 15 minutes. Take tissue paper from the kit, soak it and dispose it into the yellow color bin. Once it is cleared, the usual mopping is done. Follow spill management properly to prevent spread of infections. Recapping a needle. Ideally not to recap a needle. If necessary, always recap the right way. This is the wrong method of holding the cap and recapping. Right method is to sleeve the needle without touching the cap, then take the cap and tighten it. Needle stick injury management is very important in any healthcare setup. Once needle stick injury occurs, clean with soap and water without squeezing the hand. Once cleaned, put a sterile dressing. Look at the data of the patient if it is available for hepatitis B, HIV and hepatitis C. Make a note in the needle stick register. The possibilities are: 1. You know the status of the patient, whether they are positive for any of the three, whether they are negative, or if details of source are not available. Depending on infection, seropositivity can occur between 2 weeks to 6 months. Follow post-exposure treatment as per standard guidelines. Hand washing is the foundation of infection control practice. First, receive the hand rub solution. Second, palm to palm. Third, palm over back of both sides interlock fingers. Fourth, palm to palm with interlock fingers. Fifth, grip fingers and rub. Sixth, both thumbs. Seventh, tip of fingers on palms on both sides. Eighth, dry.
So this is important, you have to do it really for 18 to 20 seconds to be effective. So quality safety is very important in any hospital. It's a continuous process. We have key performance indicators, the time taken for initial assessment, number of errors, number of redos, medication errors. Then you have, medication chart, wherever you don't have abbreviation, adverse events, return to OT for complications, surgical site infection. So all this we have about 18 to 20 the key performance indicator. Needle stick injuries, that means the training is not good. You must avoid, not treat needle stick injuries. Absenteeism, attrition. Sentinel events are those events which are unexpected, like IOL drop, a nucleus drop, a patient having a MI or a cardiac arrest, a death, or any major or enduring loss of function are called sentinel events. Wrong patient, wrong guy, wrong surgery, wrong procedure, all sentinel events. So any such incident or event occurs, you must find out what is the immediate action we do, what is the root cause for that event, and then again take a preventive action to make sure that such things don't occur. So we have 4 committees: quality safety headed by Narendra sir, infection control by Kalpana madam, pharmacy and therapeutic by Dr. Saravanan sir, and medical records by Dr. Revati madam. They meet once in 3 months to take care of all the functions. Apart from that, we have grievances, disciplinary and internal complaints committee, atrocity against women in workplace, no blood transfusion. So this is how you have a circular, write the agenda, write the minutes and get signature and follow up every. Our biomedical equipment maintenance is 100% good. We have an inventory, we have all the manuals. We have 2 types of maintenance: preventive maintenance every month or every 2 months, and whenever there is a breakdown. So most important is downtime. Supposing you say 8 o'clock slit lamp bulb is gone, before 8:20, then downtime is 20 minutes. So critical equipment like, a defibrillator or whatever it is going to save the patient for a mini emergency, they should not have a big downtime, or you must have an alternative so that you don't land with a complication. So physical safety, you have these stretchers with the side rails, then with the belts for the, everything should be very clear across the system. No loose wires. Wherever we have 440 watts, we need to have this rubber mats. Then the oxygen cylinder should be kept, because once a full oxygen cylinder falls down, they can really hit the wall or anything and even break the hull. So powerful it will be. So they should have whether it is open or whether it's a closed, whether it is being maintained, the chart is maintained. This is something very important. Fire safety, all been trained. So suddenly you find there is a red color in one of the fire extinguishers, you please tell, because tomorrow if there is a fire around, this is not going to help at all. So you know all the important parameters. This is important to have the smoke detector and the fire panel now for NABH. Pass, you all know, pull the pin, aim at the base, squeeze the trigger and sweep the base. This is for small fires. But if the major fire, you have to call the complete code red team, and even then you have to announce the code red. Code red is for fire emergency, code blue is for cardiac emergency, code pink for child abduction. Many of the times we say code blue, it is not a true cardiac emergency, but still some team will come to save. Code yellow is nothing but emergencies inside the hospital, like electrical leak, water flooding and so on. Outside it could be a mob attack, it could be some violence or an earthquake. Code purple used to be used by some organizations for a violent or a very aggressive patient, and code black is whenever you have a bomb threat. Here you can see this training being given. I don't know how many of you have had simple methods to put out the fire, just a wet thing. So this is the right way to put the cylinder, use the cylinder for the switching off, but this is not the right way. You will contaminate the entire room. So you must know how to actually properly handle this fire extinguisher. They're all useful tools available in the hospital. The team will not come. By the team they reach, they can spread, the fire can spread across fast, very, very rapidly. So these things should be undertaken. Then most importantly, all of them will come to this area, which is the assembly area. Then there will be patients who cannot walk. So they must be shifted by the team. And then the rest of the team will also come to the assembly. These are simple methods. Without exerting, you can shift patients. Very simple methods, you can shift these patients. If there are two people, ideal for shifting one person. They'll all be taken to the safe assembly area. These are all pre-COVID times, so no mask. Here, this is a simple thing he's trying to shift. Very simple only. You know, and the smoke will go up. So you're going at a lower level so that the smoke does not cause any problem to you. So these are some of the methods you undertake. Here you can see that this is a small demo. We have to take at least once or twice a year. So when there is a fire, the immediate response is they have to go and inform the whatever number. You activate code red. One person, whether a small hospital or a big hospital, will take the nearest. You must know where is the nearest extinguisher, at least to your department. Take it and use the pass to put off the fire. That is it. Meanwhile, what will happen? All the people will move towards the assembly area. People who cannot be shifted will be carried to the safe assembly area. Ultimately, they will all reach the safe assembly area from where they will be evacuated. This is the simplest thing they will ask you. If they come for an assessment, you have to just tell this. How you use your pass, what number you will call to tell, what is the fire emergency outside, 101. That is all. This is exactly what to be done for any fire. It has helped many hospitals and many workplaces from major damage and loss of life. This is the way you should manage. Okay. So this is code 2. I think all of you know.
Tap on the shoulder.
Are
you okay?
Call. That is the first thing.
Check the correct impulse for 10 seconds. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Like that. The screen. No breathing. Call for tell. Tell. You should tell like that. Or else you should call. Activate the code blue. Code blue auditorium. You should tell like that. You should go ahead with the chest.
So this is the normal BLS.
The hand you should place at the center of the chest. Support with your non-dominant hand in the compression. How depth? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 16, 17, 18, 19, 20, 21, 22, 23, 25, 26, 27, 28, 29, 30. Place your hand here, then chin lift. This is known as head tilt, chin lift. Don't place your under the AC area, soft tissue area. Again you obstruct the airway. Just press it, then again you will the airway obstruction. So use this bony part. Okay. Pinch your nose, give 2 rescue breathing. 1 cycle. Again going for the second cycle. 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. Then until simply.
So 100 per minute, most important, you continue. Most important is during COVID-19 times, no mouth-to-mouth breathing or ambu bag. Remember, you do only compression only piece, BLS, CPR. Never give a mouth-to-mouth, I will tell you now. You have to press like the second person, not bending. Okay. See, remember, during COVID-19 times, make sure you wear some important PPE. Number two, make sure you cover the upper part of the patient's head and face. Then you start compression only PCR. You never give mouth-to-mouth breathing and nor the ambu bag, because ambu bag does not have a HEPA filter. Only ambu bags with HEPA filter can be used for BLS in cases of BLS in COVID-19 time. So never try mouth to mouth anywhere. Okay. So that is very important. Code pink is child abuse. This pediatric department or ward, you must have tagging of the parent and the child. Both the tags should have the same number. There should be similar numbers so that the wrong person will not come with the the right child. So this is going to be the way to prevent it. You must have security cameras and then you must have security people there. This is the plan for each floor. By the time we find out, the whole fire will extend, but this is mandatory. So it is important to know the evacuation plan. So the facility rounds will take care of all these things and make sure everything. So employee has got some rights, they must be treated well. They must know about the policies, their salary, their important things like ESI, Provident Fund and gratuity. So everything should be given. Responsibility, they follow working hours, they uniform, inform leave, unauthorized absence will be follow all the whatever advice is given, instructions given to them. We have a good training program. We have a calendar for that. Four important trainings are the NABH training, infection control training, BLS, and fire safety. All those four are annually to be done for every person every year. So this training calendar will make sure the whole hospital is covered. We have this profile for every employee in the hospital. For doctors, importantly, they must write the Tamil Nadu Medical Council, because medicine is a state subject. You must have a state medical council. That is all. Privileging as per your experience and your qualification. Indemnity, you must take it. Mediclaim, again, hospital doesn't take, you have to take. So trainings, all the conferences and all your publications should be there in the file. It should be completed and kept. This is how we do the credentialing, and then we do the privileging also. There are three committees. Most important, we have the grievances disciplinary committee, then you have the internal complaint. Grievances and redressal are headed by our CMO, Chief Medical Officer, and internal complaints is headed by the SMO. So basically, when there is a problem, the hierarchy would be, you tell your HOD. If it is not solved, you tell the HR. Then it will go to the committee and to the CMO. Then, depending on the problem, the action will be taken. Supposing there is a disciplinary action that somebody has taken money or somebody has stolen, then they'll be given a chance to give response within a week or two, and then their action. So the action taken could be from a warning to memo to dismissal. If somebody wants to resign or leave, they must give at least 1 month's notice. But when there is an abnormal problem, a major offense, they can be kicked out immediately. But even then, they can get the gratuity. So this is how we manage the grievances, and everybody should be aware. Disciplinary action can occur anywhere. Most important is the disciplinary action whenever there is needed. As a doctor, you must know about surgery, consent forms, discharge summaries, drug and class prescriptions, and most importantly, these certificates, what tuition certificate, leave certificate, fitness. Make sure you are giving it to the right person with the correct whatever material has to be written inside, all the correct details, and with your name, signature, date, and time. Okay. So these are the things you must follow. So basically, NABH standardizes the protocols. Checklists are there to prevent if any incident, identify when things go wrong, risk assessment, and leadership. So this is the Swiss cheese. You can see there are many holes in each of the cheese, but most of the holes are covered till the end. It will not come through. But there is one thing which can go. Say, for example, cataract, person who sees, person who investigates, person who counsels, person who admits, person who gives block, person who prepares, and person who operates. Even at one point they find out it's the wrong guy or the wrong procedure, you can stop. But even till the end, if you assume that everybody has seen the checklist, it will never occur properly. You make sure that you make sure your checklist is done properly. Don't take it for granted that everything is checked. As a surgeon, you cannot even have one sentinel event. Endophthalmitis, isolated sporadic endoff is okay because it can be due to many causes. It may not be your cause unless you are the cause for a hospital-acquired infection. But no wrong procedure, wrong surgery, wrong eye, or wrong patient should occur. Never ever, whether you do 1 lakh surgeries or 2 surgeries. So that is the most important thing. Whenever an incident is occurred, you have to make sure there is a corrective action that is taken, analyze the root cause, and then do a preventive action. So healthcare, you want the right patient, right site, right thing, right way, right time, and all the time it should be so that no harm to be done. Hospital should not be the cause for any safety related thing. Outcome, you want the best outcome. It is not the number. Number is apart from all that. Whether it is 1 number or 1 lakh, you want a very good outcome, and the end of it should be the happy moment. This is the eye care standards, which is absolutely essential for standalone eye hospitals. The standalone eye hospitals are the hospitals which can take this eye care. Not part of PSG cannot take this. So this is something which has made a lot of transparency in the process for treatment NABH in eye care organization. And this was actually formulated about 3 years back, and two of us, along myself and RDR sir, were there in the committee. And next edition should be coming, and it gives lot of value towards how we can do safely so many things. Understand, if it is not there in the document, it will not be done. It does not say you have to do this for this patient, then you will not do. If it is not recorded, that is as good as it has not been done. So if it is not documented, you cannot do it. If it is not recorded, that means it has not been done. This is the mantra for NABH. So it is important, equally important to document and record. So ultimately what will happen? The tiger will win or the deer will win? The cheetah or the deer? You never know what will happen in this competitive world. The failing deer can always be rescued by just a simple thing I just want to tell. End of the day, this is the certification we got. We are due for our NABH. So hope these are giving little bit of inputs for you all. You can just go through that 50 question answers. It is absolutely good. So you may be the person to whom they can ask a question. During virtual rounds, they can pick up a person from the employee list and call them for an interview. Or during rounds, they can ask any of these things which I told you. So please, you do not be the cause for getting one non-conformity. And forgetting about NABH and all other things, in your practice here or in your own setup or whatever you're going to start, 100% NABH will give lot of value, more safety, good brand name, and good outcomes. So definitely it will be very great. And this is what we have got in the other hospital. Hope you all and follow this NABH rules, not for the sake of following it, for the sake of getting the best outcomes for the patients. That is the most important thing. Okay, total patient care. And thank you so much.